A randomized controlled trial is a type of scientific experiment where the people being studied are randomly allocated one or other of the different treatments under study. The RCT is often considered the gold standard for a clinical trial. RCTs are often used to test the efficacy or effectiveness of various types of medical intervention and may provide information about adverse effects, such as drug reactions. Random assignment of intervention is done after subjects have been assessed for eligibility and recruited, but before the intervention to be studied begins. Random allocation in real trials is complex, but conceptually, the process is like tossing a coin. After randomization, the two groups of subjects are followed in exactly the same way, and the only difference is between the care they receive. For example, in terms of procedures, tests, outpatient visits, and follow-up calls, should be those intrinsic to the treatments being compared. The most important advantage of proper randomization is that it minimizes allocation bias, balancing both known and unknown prognostic factors in the assignment of treatments. The terms RCT and randomized trial are sometimes used synonymously, but the methodologically sound practice is to reserve the RCT name only for trials that contain control groups, in which groups receiving the experimental treatment are compared with control groups receiving no treatment or a previously tested treatment. The term randomized trials omits mention of controls and can describe studies that compare multiple treatment groups with each other. Similarly, although the RCT name is sometimes expanded as randomized clinical trial or randomized comparative trial, the methodologically sound practice, to avoid ambiguity in the scientific literature, is to retain control in the definition of RCT, and thus reserve that name only for trials that contain controls. Not all randomized clinical trials are randomized controlled trials. The term randomized controlled clinical trials is a methodologically sound alternate expansion for RCT and RCTs that concern clinical research. However, RCTs are also employed in other research areas, including many of the social sciences. History. The first reported clinical trial was conducted by James Lind in 1747 to identify treatment for scurvy. Randomized experiments appeared in psychology, where they were introduced by Charles Sanders Peirce, and in education. Later, randomized experiments appeared in agriculture, due to Jerzy Neyman and Ronald A. Fisher. Fisher's experimental research and his writings popularized randomized experiments. The first published RCT in medicine appeared in the 1948 paper entitled Streptomycin Treatment of Pulmonary Tuberculosis, which described the Medical Research Council investigation. One of the authors of that paper was Austin Bradford Hill, who is credited as having conceived the modern RCT. By the late 20th century, RCTs were recognized as the standard method for rational therapeutics in medicine. As of 2004, more than 150,000 RCTs were in the Cochrane Library. To improve the reporting of RCTs in the medical literature, an international group of scientists and editors published Consolidated Standards of Reporting Trials Statements in 1996, 2001 and 2010, and these have become widely accepted. Randomization is the process of assigning trial subjects to treatment or control groups using an element of chance to determine the assignments in order to reduce the bias. Ethics. Although the principle of clinical equipoise common to clinical trials has been applied to RCTs, the ethics of RCTs have special considerations. For one, it has been argued that equipoise itself is insufficient to justify RCTs. For another, collective equipoise can conflict with the lack of personal equipoise. Finally, Zelland's design, which has been used for some RCTs, randomizes subjects before they provide informed consent, which may be ethical for RCTs of screening and selected therapies. but is likely unethical for most therapeutic trials, although subjects almost always provide informed consent for their participation in a Rct. Studies since 1982 have documented that Rct subjects may believe that they are certain to receive treatment that is best for them personally, that is, they do not understand the difference between research and treatment. Further research is necessary to determine the prevalence of and ways to address this therapeutic misconception. The Rct method may also create cultural effects that have not been well understood. For example, patients with terminal illness may attempt to join trials as a last-ditch attempt at treatment, even when treatments are unlikely to be successful. Trial registration. In 2004, the International Committee of Medical Journal Editors announced that all trials starting enrollment after July 1, 2005 must be registered prior to consideration for publication in one of the 12-member journals of the committee. However, trial registration may still occur late or not at all. Medical journals have been poor in adapting policies requiring mandatory clinical trial registration as a prerequisite for publication. Classifications of Rcts. By study design. One way to classify Rcts is by study design. From most to least common in the healthcare literature, the major categories of Rct study designs are: parallel group. Each participant is randomly assigned to a group, and all the participants in the group receive an intervention. Crossover. Over time, each participant receives an intervention in a random sequence. Cluster. Pre-existing groups of participants are randomly selected to receive an intervention. Factorial. Each participant is randomly assigned to a group that receives a particular combination of interventions or non-interventions. An analysis of the 616 Rcts indexed in PubMed during December 2006 found that 78% were parallel group trials, 16% were crossover, 2% were split body, 2% were cluster, and 2% were factorial. By outcome of interest, Rcts can be classified as explanatory or pragmatic. Explanatory Rcts test efficacy in a research setting with highly selected participants and under highly controlled conditions. In contrast, pragmatic Rcts test effectiveness in everyday practice with relatively unselected participants and under flexible conditions. In this way, pragmatic Rcts can inform decisions about practice. By hypothesis. Another classification of Rcts categorizes them as superiority trials, non-inferiority trials, and equivalence trials, which differ in methodology and reporting. Most Rcts are superiority trials, in which one intervention is hypothesized to be superior to another in a statistically significant way. Some Rcts are non-inferiority trials, to determine whether a new treatment is no worse than a reference treatment. Other Rcts are equivalence trials, in which the hypothesis is that two interventions are indistinguishable from each other. Randomization. The advantages of proper randomization in Rcts include: it eliminates bias in treatment assignment, specifically selection bias and confounding. It facilitates blinding of the identity of treatments from investigators, participants, and assessors. It permits the use of probability theory to express the likelihood that any difference in outcome between treatment groups merely indicates chance. There are two processes involved in randomizing patients to different interventions. First is choosing a randomization procedure to generate an unpredictable sequence of allocations. This may be a simple random assignment of patients to any of the groups at equal probabilities, may be restricted, or may be adaptive. A second and more practical issue is allocation concealment, which refers to the stringent precautions taken to ensure that the group assignment of patients are not revealed prior to definitively allocating them to their respective groups. Non-random, systematic methods of group assignment, such as alternating subjects between one group and the other, can cause limitless contamination possibilities, and can cause a breach of allocation concealment. However, empirical evidence that adequate randomization changes outcomes relative to inadequate randomization has been difficult to detect. Empirically, randomization procedures. The treatment allocation is the desired proportion of patients in each treatment arm. An ideal randomization procedure would achieve the following goals: maximize statistical power, especially in subgroup analyses. Generally, equal group sizes maximize statistical power. However, unequal group sizes may be more powerful for some analyses, and is sometimes desired for non-analytic reasons. Minimize selection bias. This may occur if investigators can consciously or unconsciously preferentially enroll patients between treatment arms. A good randomization procedure will be unpredictable so that investigators cannot guess the next subject's group assignment based on prior treatment assignments. The risk of selection bias is highest when previous treatment assignments are known or can be guessed. Minimize allocation bias. This may occur when covariates that affect the outcome are not equally distributed between treatment groups, and the treatment effect is confounded with the effect of the covariates. If the randomization procedure causes an imbalance in covariates related to the outcome across groups, estimates of effect may be biased if not adjusted for the covariates. However, no single randomization procedure meets those goals in every circumstance. So researchers must select a procedure for a given study based on its advantages and disadvantages. Simple randomization. This is a commonly used and intuitive procedure, similar to repeated fair coin tossing, also known as complete or unrestricted randomization. It is robust against both selection and accidental biases. However, its main drawback is the possibility of imbalanced group sizes in small Rcts. It is therefore recommended only for Rcts with over 200 subjects. Restricted randomization to balance group sizes in smaller Rcts. Some form of restricted randomization is recommended. The major types of restricted randomization used in Rcts are permuted block randomization or blocked randomization. Block size and allocation ratio are specified, and subjects are allocated randomly within each block. For example, a block size of 6 and an allocation ratio of 2:1 would lead to random assignment of 4 subjects to one group and 2 to the other. This type of randomization can be combined with stratified randomization, for example by center in a multi-center trial, to ensure a good balance of participant characteristics in each group. A special case of permuted block randomization is random allocation, in which the entire sample is treated as one block. The major disadvantage of permuted block randomization is that even if the block sizes are large and randomly varied, the procedure can lead to selection bias. Another disadvantage is that proper analysis of data from permuted block randomized Rcts requires stratification by blocks. Adaptive biased coin randomization methods. In these relatively uncommon methods, the probability of being assigned to a group decreases if the group is overrepresented and increases if the group is underrepresented. The methods are thought to be less affected by selection bias than permuted block randomization. Adaptive. At least two types of adaptive randomization procedures have been used in Rcts, but much less frequently than simple or restricted randomization. Covariate adaptive randomization, of which one type is minimization. The probability of being assigned to a group varies in order to minimize covariate imbalance. Minimization is reported to have supporters and detractors, because only the first subject's group assignment is truly chosen at random. The method does not necessarily eliminate bias on unknown factors. Response-adaptive randomization, also known as outcome-adaptive randomization. The probability of being assigned to a group increases if the responses of the prior patients in the group were favorable, although arguments have been made that this approach is more ethical than other types of randomization when the probability that a treatment is effective or ineffective increases during the course of an RCT. Ethicists have not yet studied the approach in detail. Allocation concealment. Allocation concealment is important in RCTs. In practice, in taking care of individual patients, clinical investigators in RCTs often find it difficult to maintain impartiality. Stories abound of investigators holding up sealed envelopes to lights or ransacking officers to determine group assignments in order to dictate the assignment of their next patient. Such practices introduce selection bias and confounders, thereby possibly distorting the results of the study. Adequate allocation concealment should defeat patients and investigators from discovering treatment allocation once a study is underway and after the study has concluded. Treatment-related side effects or adverse events may be specific enough to reveal allocation to investigators or patients, thereby introducing bias or influencing any subjective parameters collected by investigators or requested from subjects. Some standard methods of ensuring allocation concealment include sequentially numbered, opaque, sealed envelopes, sequentially numbered containers, pharmacy-controlled randomization, and central randomization. It is recommended that allocation concealment methods be included in an RCT's protocol, and that the allocation concealment methods should be reported in detail in a publication of an RCT's results. However, 2005 study determined that most RCTs have unclear allocation concealment in their protocols, in their publications, or both. On the other hand, a 2008 study of 146 meta-analyses concluded that the results of RCTs with inadequate or unclear allocation concealment tended to be biased toward beneficial effects only if the RCT's outcomes were subjective as opposed to objective. Sample size. The number of treatment units assigned to control and treatment groups affects an RCT's reliability. If the effect of the treatment is small, the number of treatment units in either group may be insufficient for rejecting the null hypothesis in the respective statistical test. The failure to reject the null hypothesis would imply that the treatment shows no statistically significant effect on the treated in a given test. But as the sample size increases, the same RCT may be able to demonstrate a significant effect of the treatment, even if this effect is small. Blinding. And RCT may be blinded by procedures that prevent study participants, caregivers, or outcome assessors from knowing which intervention was received. Unlike allocation concealment, blinding is sometimes inappropriate or impossible to perform in an RCT. For example, if an RCT involves a treatment in which active participation of the patient is necessary, participants cannot be blinded to the intervention. Traditionally, blinded RCTs have been classified as single-blind, double-blind, or triple-blind. However, in 2001 and 2006 two studies showed that these terms have different meanings for different people. The 2010 Consort Statement specifies that authors and editors should not use the terms single-blind, double-blind, and triple-blind. Instead, reports of blinded RCT should discuss, if done, who was blinded after assignment to interventions and how. RCTs without blinding are referred to as unblinded, open, or open label. In 2008 a study concluded that the results of unblinded RCTs tended to be biased toward beneficial effects only if the RCT's outcomes were subjective, as opposed to objective. For example, in an RCT of treatments for multiple sclerosis, unblinded neurologists felt that the treatments were beneficial,